Thank you for being here. I am Shivani Naik, one of the PGY4 adult neurology residents. Today's talk is about immune-mediated myopathies. We're going to talk about its evaluation and the therapies that we have currently. I've always been intrigued by the autoimmunity and its effects on our nervous system. So that's why I decided we'll have a little bit of talk about immune response and myopathies. So just an overview for today's talk. We will start off talking about the classification and how it was evolved of the subtypes of immune myopathies, the diagnostic advancements in terms of its different antibodies that we have and the MRIs, and also we'll talk about the current treatment approach and what ongoing trials we have in myopathies. Evolution of myopathies, it initially started off in 1887 with just a single entity of polymyositis. And it has come a long way since then with multiple revisions in the classification of myopathies. It was up to like 100 years later that we have an entity called as inclusion body myositis, and then in 2018 it was revised, and as of now the entity that we started off with, that was polymyositis, it's absolutely not there as a separate classification. Although having said that, this classification is not absolute, and they have been back and forth in terms of how to classify myopathies, and it's still going on. So I'm not sure if down the lane we have more classification for myopathies. Having said that, this was an article that came up back in 2010. Neurologists are from Mars and rheumatologists are from Venus. The reason why I kept this article here was it's like myopathies are being with neurologists and at the same time with rheumatologists, and we kind of work together or separate in identifying the classification. So even now, we are still trying to come up with the common ground to have the myopathies classified, but we are still working on it. So hopefully down the lane, eventually we'll have one classification that is followed by both neurologists and rheumatologists, but we'll see. Okay, so inflammatory myopathies, as of now, we have divided into three categories. One, dermatomyositis, antisynthetase, which was initially called as polymyositis, but we now call it as antisynthetase. And then we have immune-mediated necrotizing myopathy. Along with all this, we have a separate category called as inclusion body myositis. With the first three, dermatomyositis, antisynthetase, and necrotizing myopathy, the initial presentation, as you can see over here in the figure, the initial pattern of muscle weakness is usually proximal. So it's kind of difficult to diagnose, or just by having the first presentation of the patient, because they all can have a similar type of muscle weakness. The only way previously to classify these three was based on histopathology. And we see a different kind of histology for all these subtypes. When it comes to inclusion body myositis, the pattern of weakness is very different. So in inclusion body myositis, we usually have weakness in our flexors and in our quadriceps as compared to the other inflammatory myopathies. So that is the major difference in terms of the initial exam for these patients. So I'm going to move ahead and I'm going to talk about the different diagnostic tools for each of these subtypes. and how it has evolved and what we can do differently as physicians in diagnosing these myopathies. So we'll talk about the autoantibodies for these and at the same time muscle MRIs, because each of the myopathies have different autoantibodies and different type of muscle MRI. So starting off with dermatomyositis, I'm not going to go that much into pathophysiology of these myopathies because we do have a lot of information, a lot of literature on how it has evolved and the treatment option for that. But then again, there is also a lot of controversy. For dermatomyositis as a whole, it has interferon overproduction, and at the same time, there is class 2 HLA alleles, and environmental exposure plays a major role in pathology for dermatomyositis, and hence, at the same time, complement as well. And therefore, we have the treatment option targeting those areas. When we come for the dermatomyositis, one of the major things that we have learned over the years is the skin manifestations. And as you can see over here, we do have a shawl sign, and then we have, where you can see my arrow, we have Gottron papules, and some patients do have telangiectasias, and some patients with different kind of antibody can have calcinosis as well. So it just depends on what antibody the patient with dermatomyositis has, because clinical manifestation can vary. And the histology that I have put over here, in dermatomyositis, there is atrophic muscle fibers, and you can see some perivascular inflammation as well, and the atrophic muscles. So this is the skin manifestation for dermatomyositis, but not all patients will have all of these signs. Moving ahead, dermatomyositis can also affect other systems other than muscles and skin. You can have cardiac, pulmonary, GI involvement, can have pericarditis, myocarditis. Interstitial lung disease is it can have a very serious complication, and it can be a cause of death with patients with dermatomyositis. At the same time, you can also have GI tract involvement and can cause vasculopathy, causing ulcers, perforations, and GI hemorrhages. So dermatomyositis as an entity can affect multiple systems. Moving ahead, when we do suspect dermatomyositis in patients, the first thing that we want to look at is the CK. CK in dermatomyositis can be normal, so we cannot completely rely on CK for dermatomyositis. It can be normal or it can be less than 1,000. You can also have AST, ALT elevation because it can affect the liver, and it's important that we check GGT, which is very liver specific in patients with myositis. The patients who does not have liver involvement, the GGT will be normal. Moving ahead, this is the slide that I want to spend a little bit of time on, is different autoantibodies with dermatomyositis. We now have 5 of them, and I'm sure down the lane we may have even more. But as of now, the one thing is MI2. This MI2 will have classic cutaneous manifestations, and this antibody typically responds well to immunotherapy. The next one is TIF1 gamma. This antibody is very highly associated with malignancy. So it's important to, when we are thinking about dermatomyositis, it's important for us to check all the antibodies because each of them will have different kind of presentation. So TIF1 is very highly associated with malignancy, and we need a very 3 to 5 years of cancer screening if we do have TIF1 gamma. it's similar to when we talk about NMDA, it comes into our head like, yeah, that is associated with some kind of cancer somewhere. So when we are talking about TIF1 gamma and dermatomyositis, it's important for us to know that it is also associated with malignancy. Then we have NXP2, which is where we can see calcifications. So those are the small things that are like different in different antibodies. MDA5, this is also very important because this antibody will have rapidly progressive interstitial lung disease. And very common in Asian patients to have this antibody and will have interstitial lung disease. Also, you can see some skin ulcerations too. The last antibody is less frequent, but it has good prognosis. So the main thing to remember in this would be the first four, TIF1 gamma with high risk for malignancy, MDA5 with increased risk for ILD, and so forth. Moving ahead, that was for dermatomyositis, just for the antibodies. We'll talk about the MRI and things further. Moving ahead, we have this antisynthetase syndrome, which was initially termed as polymyositis. So this particular syndrome, you will have proximal weakness in upper and lower extremity, but also associated with this, you can see interstitial lung disease, which is very common as compared to dermatomyositis. You will have arthritis, mechanic's hand, Raynaud's syndrome, fever, or just usual arthritis. These patients can also have a rash. That's why it's kind of important for us to have a broader outlook when we are kind of seeing these patients, because they both can look similar at times. Most common antibody in this antisynthetase syndrome is anti-Jo1 antibody. That is the most common, but as you can see, I have marked over here, anti-PL7 and PL12, these two antibodies are associated with highest risk of ILD, that is interstitial lung disease. So far, we have 8 antibodies for antisynthetase. Out of them, at least we need to remember the first 3 and their different presentations. PL7 and PL12 are high risk for interstitial lung disease as compared to others. And again, with the histology, we do see perivascular, you see muscle fiber necrosis, and there is some inflammation in the perimysium, and inflammation around the surrounding vessels as well. So when we are talking about these antibodies, there was a paper that came out in 2017, published in Rheumatology Journal, which did study a large number of patients with antisynthetase syndrome. And from that paper, we now know that 90% of the patients who have PL12 and PL7 as antibody will develop interstitial lung disease. And it can develop even prior to myositis. So they may develop ILD before even having any kind of weakness. So that's important for us to know as well when we are kind of looking for these patients. Okay, so the third entity that I was going to talk about is immune-mediated necrotizing myopathy. So in 2017, European Neuromuscular Center criteria described the 3 subtypes of these myopathy. One is anti-SRP myopathy, the other one is anti-HMG-CoA reductase myopathy, and then antibody negative immune-mediated necrotizing myopathy. Well, the clinical hallmark for all immune-mediated necrotizing myopathy is the presence of proximal muscle weakness. And extramuscular involvement, as we saw in dermatomyositis and antisynthetase, is rare. So this particular group is mainly focused on muscles, and you have more of a muscular involvement than anything else. So for anti-SRP antibodies, it's usually aggressive, and in these particular patients, the CK level is extremely high as compared to dermatomyositis. You can have early onset dysphagia, and these patients may not respond that well to immunotherapy as compared to the first two. We see anti-HMG-CR antibodies quite often, at least here. It was first described in 2010, this particular antibody, after a statin exposure. But over the years, we have learned that it can happen in statin-naive patients as well. There are certain kind of foods which in day-to-day life we are exposed to statin. So we cannot completely say that, it's statin-naive patients, but you have statin exposure in oysters, mushroom, red eyes, yeast. Identifying these particular set of myopathy is important because they are very aggressive and it requires aggressive immunotherapy right from the beginning. Moving ahead, the histopathology for this particular subtype, you see a lot of macrophages. In fact, the numerous macrophages around the myofibers are the possible cause for necrosis in these patients. And you can see it perivascular and perimystial, as we saw earlier in dermatomyositis and antisynthetase as well. But here, the main thing is about the macrophages, which invades the myofibers. Moving ahead, I want to talk a little bit about inclusion body myositis. Although we, as of now, don't entirely know how the pathophysiology for inclusion body myositis takes place. We do know that in IBM, we have atrophy, and at the same time, we have inflammation. So there is muscle degeneration, and at the same time, we have inflammation. So there was this paper that came out in 2015. It's amyloid deposits and inflammatory infiltrates in sporadic IBM. The inflammatory egg comes before the degenerative chicken. So it's still an argument what comes first. But after reviewing this paper, most of them believe that there is an inflammation which formulates a cascade, and then there is a degeneration as well. So IBM is one of the most common myopathy over the age of 45. It is slowly progressive, and you see over here in this picture, you have weakness of the flexors in the upper extremity, and you have weakness in the quadriceps, mainly proximal weakness in the lower extremity and distal in the upper extremity. Again, there is a question whether it's autoimmune or it's neurodegenerative, or is it both? So we still don't know. But when we talk about IBM, you can see over here, there is very much, we can see the muscle wasting here. There is a weakness in the proximal muscles and the flexors specifically. And over here in the histology, you can see there's a very specific, for IBM, the histology is quite helpful because you do see vacuolar changes over here, here, and even over here, if you can see my arrow. So histology can be quite helpful in IBM if we do see vacuolar changes. Moving ahead, we do have a blood biomarker for IBM that is anti-NT5C1A. I think this particular study came out in 2013. Which reports the sensitivity and the specificity of this blood biomarker. And it was quite helpful because many of the patients, as much as 30% of the patients who were initially diagnosed as polymyositis, once this blood biomarker came out, it was these patients were then called as IBM because of this biomarker, and the sensitivity for it goes up to 80%, and specificity for this biomarker is 100%. Although, having said that, this particular biomarker can also be found in SLE and Sjogren's. But if present in these two conditions, we typically don't see myositis. So there was a study which was done in 2017. It was a large cohort of like 300 patients, and they studied this biomarker because in IBM as well, not all patients are seropositive with anti-5C1A. So they did a study with 300 patients, and the final results was like the seropositive patients with anti-5C1A had more aggressive course of the disease and more motor involvement as compared to the patients who had negative blood biomarker. So it's important for us to even test so that we can at least talk about this with the patients in terms of the prognosis down the lane. So this is the overview about the antibody and different subtypes. So I'm just going to talk a little bit and just highlights on the major stuff. For dermatomyositis, so you can see the first three, dermatomyositis, polymyositis, or antisynthetase, and immune-mediated myopathy. They all have symmetric and proximal muscle weakness. In dermatomyositis, there is a lot more skin involvement. In antisynthetase, you have more of a lung and joint involvement. And in necrotizing myopathy, it's purely muscular involvement with very approximately, we don't see any extramuscular involvement in this particular entity. And as I said earlier, in IBM, you have finger flexors, quadriceps, and it's asymmetric muscular involvement. Histology for this dermatomyositis, you can see perivascular atrophy. In antisynthetase, you will have necrosis, and in immune-mediated as well, you will have necrosis, but no inflammation. And the classic IBM, you will see rimmed vacuoles. That is very important. And when it comes down to CK, the first two, dermatomyositis and polymyositis or antisynthetase, CK can be normal or close to 1,000. But it's really important for us to see if the CK is more than 1,000, then we kind of lean towards necrotizing myopathy. And even for IBM, it can be normal. So first three response to immunotherapy. For IBM, so far we don't have any kind of response to immunotherapy. This is again the antibody. As we talked about TIF1 gamma, the main thing for this is cancer, and then MDA5, the main is for lung. Again, coming down to antisynthetase, Jo1 is more common, but P7, PL7, and 12 will have a lot more lung involvement, causing ILD, interstitial lung disease. And in necrotizing, it's only muscle involvement. This was in neuromuscular continuum, which was there in 2019. So having talked about like so many antibodies, what is the yield of doing antibody testing to the gold standard biopsy? So there was this paper in 2015. It was a cohort for like specifically for dermatomyositis and Jo1. So in this paper, they studied the histology, and they also had the serum to test the antibodies. So when we are talking about the histology, definitely we will be able to say, yes, it is a myositis. Because we can see inflammation, we can see atrophy, but then it comes a point that we are not able to identify the subclass of myositis. For example, in DM as well, we have so many different type of antibodies, and each antibody has like their own specific presentation. So just based on the pathology, it's kind of difficult for us to do that. So this is the study that came out, and as you can see over here, you can see inflammation in about 62% of all DM patients, and as well as atrophy. My point being that is it's important for us to test for all antibodies as well, along with the histopathology. So as I said earlier, the classification for myopathy is still evolving. So this particular article was published in JAMA, and they are now saying that they are developing a new classification for myopathies based on solely clinical manifestation and autoantibodies, and not requiring to do biopsy. But I don't think we still do biopsies, but this was their classification, and they had this kind of pictorial depiction of different kind of entities, and as you can see over here, dermatomyositis and antisynthetase will have extramuscular involvement as compared to necrotizing and inclusion body myositis. It's more of a muscular involvement. But again, this is not absolute, and we still do the biopsies even here. Moving ahead, I want to talk about the MRI in muscle disease and use of MRI in muscle disease. It is a very non-invasive tool to aid the diagnosis. It helps to guide the muscle biopsy. And different type of myositis will have different MRI changes. It can be helpful in assessing if there is a flare-up and also monitoring the disease activity. I'm going to talk about a normal MRI first, and then we'll talk about what we see in these myopathies. So typically when we are looking at the muscle MRI, the two main sequences that we want to focus on is STIR and T1. In normal, when we are looking at STIR, the edema, if we do see edema, it will be bright and it will be low on T1. And fatty infiltrations will be low on STIR and it will be bright on T1. So these are the two main things that we focus on when we are looking at the muscle MRI for myopathies. And of course, in the normal muscle, we would not see, it will be low for both STIR and T1. We would not see any changes in that. So having said that, we are going to talk a little bit about the MRI. So edema, if we do see edema, it represents active disease. That means it may be inflammation or necrosis. And if we see fatty replacements or muscle atrophy, that means it is a chronic process and it may be irreversible at that point. My point being, if we do see edema in the MRI, that means it is active and we can be more aggressive in terms of immunotherapy if we see a lot of edema as compared to the fatty replacements. So this was a study where they have checked thigh muscle MRIs for immune-mediated necrotizing myopathy and different kinds of myopathies. So I'm going to move ahead and show you the pictures. As you can see over here, the first one is normal. We don't see any signal change over here. In immune-mediated myopathy, in the first slide, you can see there is so this is T1, and as you can see, there is an increased signal up here and down here, which represents there is some kind of inflammation going on. Now, at the same time, if you go down and if you see an IBM, so IBM typically affects one particular anterior or posterior side of the muscle. So over here, you can see over here, this side of the muscle is very much affected than the posterior. And when you come down to dermatomyositis, the classic finding that we see in the MRI is you see the fascial edema. So surrounding the muscles, you see there is a hyperintensity, increased signal that is typically seen in the dermatomyositis as compared to the other groups. So this is just a close-up picture for all of these. So in immune-mediated necrotizing myopathy, you see hyperintensity throughout the signal in the STIR. And as I said earlier, these patients will have a CK elevation more than 1,000, up to even 10,000. Again, coming down over here with dermatomyositis, you can also see calcification, which would be hypo intense, as you can see marked with the yellow arrow over here. And again, you will have these fascial edema, which can be seen in dermatomyositis, particularly as compared to the other myopathies. Coming down for the IBM again, you see there is severe fatty infiltration in the flexors, in the forearm, and again, you see infiltration in vastus lateralis and sparing of rectus femoris over here. So that's what IBM does. It skips the muscle groups when affecting a particular proximal or distal musculature. So it skips the muscle groups. That's what they are trying to identify in this picture. So MRI sensitivity and specificity. So MRI can pick up a lot of things. So as you can see that we can see edema, but so the sensitivity would be 100%. But at the same time, the specificity would be low as compared to the specificity for muscle biopsy. That would be 100%. The reason being, you can see increased signal even if there is a trauma or any kind of rhabdo. To be honest, with anything that would affect the muscles, you can see the edema changes on the MRI. And that's the reason if we do both biopsy and MRI, the false negative ratio comes down from 0.23 to 0.06%, as they did in this study, which was published in 2017. The only reason for this being is, like, at times when we do biopsy, we may biopsy the muscle that is not affected, and the results will be like negative at that time. So it would be beneficial if we do MRI first and see which muscle is affected, and then do the biopsy. So that decreases the false negative rate. So again, moving ahead, as I told earlier, each of the myositis has different MRI patterns. Dermatomyositis will have edema around the fascia. Immune-mediated necrotizing will have more edema, and severe fatal filtrations can be seen with SRP antibodies. And the muscle groups affected is also important to distinguish between these different types of myositis. For IBM, as I told earlier, it is asymmetric and will affect the finger flexors and proximal musculature in your lower muscle groups. So having talked about like the antibodies and the MRI, I was just going to run through cases and whatever we have come across. I have two cases that we did see over here at Louisville, and then there is one case that I read from Continuum. So case one, and so this particular patient, she is 63 years old. She came to the clinic with a diagnosis of dermatomyositis. She was treated with IVIG. She was on high-dose steroids, but despite of all this, she was having progressive weakness and dysphagia. So we know that dermatomyositis, if we treat the patient, it's very responsive. So she came up with this presentation and the diagnosis. Sorry, I forgot to mention CK, but CK for her was less than 1,000. I believe it was around 575. She had the malignancy eval. For dermatomyositis, as we know, we do have to check for malignancy. So she did have this eval, which was negative, and the myositis panel came back positive at TIF1 gamma, which is again associated with high risk for cancer. CT chest, abdomen, pelvis was negative. So the PET scan was ordered, but then insurance denied the PET scan, and it was done after like multiple appeals. So the PET scan showed nasopharyngeal carcinoma, as you can see that I have pointed out here. My point for this slide is that we know TIF1 gamma is associated with cancer. Once she was figured that she had this nasopharyngeal carcinoma, she was treated with radiation and chemo, along with IVIG, prednisone, and methotrexate, and eventually all her strength was improved. She's now working, and she continues to be under surveillance. So it's important for us to vouch for the patients when we do know that particular antibody is associated with high risk for cancer. Again, the cancer screening recommendations. I'm going to move a little bit faster because don't have much time, but this PET and CT, combining both or just doing the PET alone in patients who have increased risk for cancer is very important. Again, the cancer risk for dermatomyositis with this particular antibody is about 80%. So you need to know the risk with the particular antibody, so it's helpful when we are appealing for the insurance. This we already talked about TIF1 gamma and NXP2. When we do see these antibodies, we recommend extensive cancer screening for at least 3 to 5 years after the diagnosis. So case 2, this was a patient, 61 years old, African-American, came with a history of hypertension, diabetes, prostate cancer, came with progressive weakness in proximal muscles. This patient had been exposed to atorvastatin in 2014 to 2015. At that time, he had the first episode of rhabdo with weakness, and statin was discontinued. So this patient came, I think, about 3 years later after that, and at the presentation, his CK was more than 4,000. He did get the biopsy, which again showed a diffuse myopathy, but we don't know what exactly the type of myopathy a patient has. And that's the case with most of the histology samples. Then in 2017, we did send all the antibody panel, myositis panel was sent, and everything came back negative. My point being for this slide is HMGCR antibody was positive. We did send out the myositis panel, but that particular panel does not have HMGCR antibody included in that. So it's important for us, even as residents, to know when we do send out these panels, and we need to make sure that we send out all the antibodies correctly. So this patient had refractory course and is currently on rituximab and doing well. So CK improved from 4,000, now it's 257. The strength at the initial presentation was 3/5, and now it's improved to 4. The course is now stable, and he has not had any exacerbation in over 1 year now. So this was the patient that we saw over here at Jewish. And this is the last case that I have so this is 57-year-old patient that came in with a weakness, again, had a spine surgery done way back, had a revision of the spine surgery because they thought that the weakness is because of that. Did not improve. She was no longer able to ambulate by 2015 and also developed dysphagia at that time to solids. CK was elevated to more than 6,000, and the biopsy of the left biceps was done, which, as you can see up here, which was done at our place. We see frequent regenerating fibers. We don't see any rimmed vacuoles, so that excludes IBM. So in the impression, again, it's just inflammatory myopathy. We don't know what type. So the myositis panel came back for SRP positive antibody, and the patient was started on solumedrol. And the one more important thing in this is when we do start the patient on steroids, early or rapid steroid taper can increase their weakness and exacerbate their symptoms. So this patient was started on methotrexate at that time. And over the course of her time, CK, aldolase, ESR, CRP are all normal. One thing that I want to highlight on HMG-CR antibodies is that it may resemble limb-girdle muscular dystrophy, and it has and we have a lot of papers now coming up with this. So this particular article, they had 11 patients who were diagnosed as limb-girdle and never received any kind of immunotherapy. So they included the patients with a particular pattern of limb-girdle, pattern of weakness, which is similar to myopathy, and genetic panel for these patients was unrevealing, yet they had the diagnosis of limb-girdle. 6 of these patients were diagnosed as HMG-CR. So it's important for us to know, since the pattern of weakness can be similar, patients who have had limb-girdle muscular dystrophy as a diagnosis, we need to make sure if they have the genetic testing, and if it's unrevealing, it's better to test for HMG-CR antibody as well, as we can see this even in statin-naive patients. So the treatment strategy for DM particularly is extremely responsive to immunotherapy. At this point, we don't have a correct treatment approach, but the first line for most of the myopathy is steroids. The second line, we do use methotrexate, azathioprine. Then we have IVIG as well, which we do use a lot more for dermatomyositis, given that there is a complement pathophysiology as well. And then rituximab is mainly used for refractory disease. The last 3, cyclosporin, tacrolimus, and cyclophosphamide, we do have less evidence for these treatment. So myositis treatment, as an overview, this was published in Continuum in 2019. So for the mild weakness, we usually start with prednisone, wait for 2 months. If we see no response, then we either go to azathioprine or methotrexate at that point. Over here, although they have not mentioned for how long to wait to see if there is a response or no, but again, we can also try IVIG at this point if there is no response. If there is no response after all of this, then we go to then it is kind of refractory, and then we use rituximab, cyclophosphamide, tacrolimus, or cyclosporin, any of these third-line agents. And if it is IBM, as of now, we don't have any kind of immunotherapy that can help the patients with IBM. So this is particularly for first 3 entities of myopathies. Also, this is just a summary of the myositis in the trials for the third line agents that have done so far. Out of all of this, we do use rituximab over here quite often as compared to others. Abatacept is a T-cell targeted response, and right now it's actually people are reviewing this particular drug quite often, and we do have studies for those drugs. There are other investigational agents as well, JAK inhibitors and cefalimumab. JAK inhibitors is basically acts on interferons, and as we know, interferons are very heavily involved in the pathophysiology for dermatomyositis. So this particular ruxolitinib is JAK inhibitors, which they are currently studying for dermatomyositis, and it is an open label, and they are still recruiting. The main concept for this JAK inhibitor is that it acts on the interferon, and it inhibits the inflammation and cytokines, and that's why, since it is the interferons is very highly involved in dermatomyositis, this particular agent, they are now studying it for the dermatomyositis patients. Coming to the treatment of IBM, I have listed all the immunotherapies and the therapies that have been tried since 1990s up to now. So you can see over here, we have tried corticosteroids. There have been studies on methotrexate, azathioprine, IVIG, anakinra, etanercept, alemtuzumab, and a lot more. So far, none of these treatments have shown to be beneficial for the patients with IBM at all. So for IBM specifically, right now, if the patient is on any kind of immunotherapy and we do know it's IBM, it's better to discontinue the immunotherapy because it's not helping, and the added side effects from the immunotherapy are a lot more. Then, unfortunately, as of now, we have supportive care, and then there are ongoing clinical trials that the patient can get involved in for IBM. One of the trials that was kind of interesting for me was this myostatin antagonist. It is basically BYM338 monoclonal antibody. So it was by Novartis, and the concept for this study was myostatin. It acts on activin 2B receptors. What it does is it's in the normal person, it upregulates atrophin gene and downregulates myogenesis. So the idea was if we block myostatin, there may be increase in the myogenesis. So this study was done in a quite large patient population, but the study failed because it was nobody met the primary outcome of improvement in 6-minute walk test for 6 weeks. So this study was stopped after that. What they saw after doing this study was there was an increase in the muscle mass, but there was no increase in the strength even after doing this therapy. I have just listed, in the end, I have just listed the myositis antibodies, where it goes. The reason being that we need to know the myositis panel won't have HMG-CR, it won't have SRP antibodies, so we do have to order those separately. Even the extended myositis panel will not have HMG-CR antibody in it. So treatment strategy, this is, I think, my last final slides. So treatment strategy for us, if we do suspect dermatomyositis, that means if we do see rash myositis, we are thinking about dermatomyositis. At that time, we do send myositis panel. The second entity is antisynthetase. If we do see myositis along with joint pains, rash, lung disease, again, we do send myositis panel, but you need to make sure that you send out the proper panel, including all the antibodies for these. For DM, if we see there is a TIF1 gamma or NXP2 antibody in the panel positive, or MDA5, we have to do the cancer screening for 3 to 5 years from the onset. MDA5 is very highly associated with interstitial lung disease, and that's the reason we need to monitor their pulmonary function test every 6 to 12 months. And coming back over here, if it is antisynthetase antibody, again, pulmonary function test is very important because there is a high association for interstitial lung disease with these patients. Coming down to necrotizing myopathy, we see severe weakness, extremely high CK, and lack of inflammation on biopsy. That is the clue for this particular myopathy type. And then we do order HMG-CR and it's positive, or if we have SRP antibody positive, either or, I think it's very important to have them on an aggressive immunotherapy. Of course, if they have statin exposure, we do discontinue the statin. We can have IVIG steroids and methotrexate for them. SRP is even more aggressive than HMG-CR, and as a reason for that, we usually end up to rituximab for these patients. Then this is the third type. if the patient has a history of diagnosis of PM, like polymyositis, and the patient has had no response to immunotherapy and is over 45 years, that is a clue that this could be IBM. And in that case, we do test NTFC1A antibody, which is a biomarker for IBM. And if that's positive, we taper off the immunotherapy, we do the supportive care and the clinical trials for these patients. So having talked about all of the myopathies, I think the first and foremost thing for us, we know that it's diagnostically challenging. Although we have all of the antibody testing, biopsy, MRI, and like a lot more investigational thing, history and detailed physical exam as a neurologist is extremely important, and I don't think any of the other testing can take away that. So we need to make sure our exam, and we need to know what kind of muscle weakness so that we have an idea when we are seeing the patients as to what we are dealing with. And then definitely diagnostic process, we have antibodies, muscle imaging. Also one thing, DM and antisynthetase and necrotizing myopathy, they are treatable unlike IBM. I have listed the ongoing clinical trials, which are currently recruiting patients for myopathy. As I told earlier, abatacept, the T-cell inhibitor, is currently going on at multiple sites in US. These are the trials just in US, so there are like multiple other trials going on too. And for IBM too, there is a trial for sirolimus, which acts on the mTOR pathway, which is going on at Johns Hopkins. So all of these trials, they are currently recruiting and ongoing over here. For IBM, unfortunately, there are not many, but sirolimus is one of the drug trial which kind of looks promising, but again, not sure. Then we do have stem cell therapy for IBM, which is going on at UMKC, as well as stem cell therapy for dermatomyositis, which is going on at University of Florida. And there is a drug called nivolumab. It's nothing but IgG4. That is also going on across multiple locations in US, but it's not just for dermatomyositis, it's for any kind of autoimmune disorder. But I think that's all for the current myopathy treatment options. Any questions, comments? I think it did end right on time.
It was very good, Shivani.
Thank you.
Thank you, Shivani. We loved it.
Thank you.
Shivani, can you hear me?
Yes.
So, first of all, thank you for choosing this topic. I'm maybe a little bit biased, but I think it's a great topic to talk about. I think if you've probably learned that if you do a literature review about myositis, it can be really confusing because, for one thing, over the years, the classification, the description, the terminology of what's polymyositis, what's dermatomyositis, immune-mediated necrotizing myopathy, there's a lot of mixed, there's a lot of confusion about what is what, and what used to be called polymyositis may have been this immune-mediated necrotizing myopathy, might have been IBM. In fact, the first description of IBM was not IBM, but what is cited as the first description of IBM is actually a hereditary condition. So, and thank you for saying the importance of a history and exam. Inclusion body myositis is one of the two muscle diseases that can be diagnosed with a handshake. Does anyone know the second one that can be diagnosed with a handshake?
Myotonic.
Yeah.
Myotonic dystrophy, right? When the patient can't let go, that's your buzzword if you're taking an exam. That's that's the answer. But with my IBM, the handshake is so they don't have finger flexors. They don't have these muscles are all weak, and so when they shake your hand, it's kind of like this. And so if you shake the hand, well, when we used to shake hands before COVID, you could diagnose this condition with a handshake, and it was just sort of this weird pincer grasp. And then the other thing about IBM is the history, and the history of IBM is it takes a long time to get diagnosed because a lot of people just feel like they're getting old. IBM changes so slowly that it just seems like I'm just getting old. That's what a lot of people will tell you, and they will have had a surgery for spinal stenosis, spinal canal stenosis, and the surgery doesn't help. And it's important to know if it's IBM because you don't need to keep this person on immunosuppression. And the immunosuppression is actually more dangerous than the disease, although the disease can eventually be dangerous too. And then, as you mentioned, the important thing about the necrotizing myopathy is that the HMGCR is not on any of the myositis panels. If you check ARUP, LabCorp, Quest, you have to order it separately. So when you see that someone has a myositis panel negative, check what was on that panel because it doesn't include HMGCR and sometimes it doesn't include TIF1 gamma. Yeah. TIF1 gamma needs to be checked because that's cancer until proven otherwise. And then as far as your myositis treatment slide, I think if you're going to write a cookbook, you want to actually have pretty clear instructions, and that cookbook doesn't really have clear instructions. And so the algorithms work sometimes, but in terms of myositis, I don't know that the algorithms are all that helpful. But thank you for the topic, and thank you for presenting today. And
thank you, Dr. Brown, for all the help.
We all loved it. Thank you.
Thank you. Bye. I'll see you, Dr.
Brown. Questions.
Yeah. Bye.
Bye.